Thank you very much. I've seen, just noticed that 3 of the speakers are from the UK for this, and there's a British flag. I think we should have an Indian flag here as well, because all of us have dil that's in Hindustan. So thank you again for the invitation. These are my disclosures. So over the next few minutes, I'm going to go through background to holistic care, evidence for early interventions, guideline recommendations. This is what we call efficacy to effectiveness gap and potential solutions. So in terms of the background, we know that diabetes is a multi-system disease. There's multiple defects that contribute to development of hypoglycemia and then eventually diabetes. And that's why a single intervention is never going to be enough to control hypoglycemia and prevent people from getting not only hypoglycemia but also complications as well. These are data from Sweden, similar data in US as well, that we are improving outcomes for people with diabetes. So as you can see, over 20 years there's been reduction in death from any cause, death from cardiovascular disease, death from coronary heart disease, and hospitalization for cardiovascular disease. In the red is the matched control population with diabetes, and blue is the people with type 2 diabetes. So although there's reductions, the gap still remains between people with diabetes compared to the matched control population without diabetes. Over the last 10 years or so, we've been putting a lot of emphasis on cardiovascular outcomes and preventing cardiovascular outcomes because of the cardiovascular outcome trials. So this is, I think, probably one of the largest observational prospective studies. We conducted this as a part of the Discover program. 33 countries, we had about 15,000 patients. Participants here, we're just showing data for 33 countries because of data issues, getting data from the other countries. But what we see on the right-hand side is the cardiovascular disease risk is improving. As you can see, there isn't a huge increase over the 3-year period. Starts at around 13%, it's at 15% over a 3-year period. On the left-hand side is the cumulative risk for microvascular complications. As you can see, there we see still steep rises. And the main reason, I think, is because we've been putting too much emphasis on cardiovascular outcomes and not so much on glycemic control. That was talked about eloquently by Wazim. So what's the evidence for the interventions? Well, we have the UK PDS Accord Advanced VADT. We see that if we go early enough, we get reductions in microvascular complications. And if we start very early from diagnosis, like UK PDS has shown, we will get associations with reduced complications for cardiovascular disease and possibly mortality as well. All the others, people had diabetes for about 10 to 12 years. And so we didn't see any benefits in terms of cardiovascular outcomes, but we did see benefits for microvascular outcomes. We now have excellent data for the organ protective therapies. So this is Seto Knutzer, who did this from our group, looking at 20 randomized control trials for SGLT2 inhibitors. And we see 3-point MACE reductions of around 12%, significant reductions for 3-point MACE. We see around 40% reductions for microvascular disease, and combined micro and macrovascular, we see about a 14% relative risk reduction. Similarly, we have GLP-1 receptor agonists at our armament, and again, we see microvascular benefits, 3-point MACE reductions around 15%. Microvascular benefits about 14% relative risk reduction, which was significant again. And so we have excellent data from randomized control trials, not only for glucose control, but for organ protective therapies as well. And then we have data from lots of other studies looking at legacy benefits for risk factor control. Most of the time we talk about legacy benefits for glucose, but there are legacy benefits for blood pressure. Glucose, as you know from the UK PDS, 44 years from when the trial started, so 24 years from when the trial finished. For blood pressure, we have 10-year legacy benefit data, lipid lowering 18 years of benefit data. And for multiple risk factor control from the STENO trial, we have 21 years of data of legacy benefits there. What do the guidelines tell us? Well, guidelines are now very well evidence-based for the first time. Previously, we could do anything we wanted. But now on the left-hand side, if they've got cardiovascular disease or very high cardiovascular risk, we start on organ protective therapies, GLP-1 receptor agonists and SGLT2 inhibitors. And that's about 30% of the population. For the 70% on the right-hand side who don't have those cardiovascular disease, then we can opt for any therapy depending on various characteristics of that person who's in front of us, including cost as well. I always ask this at every meeting. How many people have seen this? Come on, everyone's seen this at a diabetes meeting. Yeah. How many can tell me what that blue circle is on the right-hand side? No one can tell me what that blue circle is. So we'll come to that. You've seen this hundreds of times, but you can't tell me what the blue circle is. We'll come to that shortly. So the key goals are cardiorenal risk, as we've heard from the previous talk, because there are multiple risk factors that we need to manage, including HbA1c, blood pressure, lipids, BMI, smoking, etc. So in terms of therapies, we have a huge number of therapies at our armament. Metformin, obviously the first line, and then we've got the sulfonylureas, TZDs, DPP4 inhibitors, SGLT2 inhibitors, and incretin receptor agonists. And now we're seeing dual receptor agonists and triples are on their way, and there are 70 molecules in development at the moment with the GLP-1 receptor class. So lots more coming in as well. So we can't say we haven't got enough therapies there. All of them have benefits in terms of glycemic control, some more than others. Hypoglycemia risk with some, such as sulfonylureas and insulin. Weight gain with some. So lots of options depending on what we're looking for that person who is in front of us. So despite this, despite all the evidence base, we still are not translating this into clinical practice. And this is what we call the evidence to effectiveness gap. Efficacy to effectiveness gap. Efficacy is what we see in a randomized controlled trial, get huge benefits, but they don't translate into the real world practice that you and I will be looking after the patients in. And there are a number of reasons for evidence to effectiveness gap, and one of them is therapeutic inertia. We used to be called clinical inertia, but we now call it therapeutic inertia, and that's where the blue circle comes from. The blue circle is on most of the guidelines now, not just for diabetes, for other guidelines as well. To avoid clinical inertia, reassess and modify treatment regularly, every 3 to 6 months. And that's exactly what we are not doing for our patients. Therapeutic inertia is failure to advance therapy or to de-intensify therapy when appropriate to do so. So when we don't intensify that therapeutic inertia, but at the same time, if patients are elderly, frail, they're on therapies that cause hypoglycemia or hypotension, we don't stop that, that's also termed therapeutic inertia. And this is the evidence, and there's lots of this evidence around. So this is from US 20-year data. As you can see, despite all of these fantastic therapies, glycemic control is a flat line. About 50% of people are achieving a target of less than 7%. Blood pressure targets improved, but again now, if you look at type targets, it's about 50%. Lipid targets improved, but now again showing we're stagnant. And when we look at all three risk factors, we said multiple risk factors are important, about 22 to 30% of people are achieving all three risk factors, and we see this in the UK as well. And one of the reasons it says the therapeutic inertia, just to show this from the Discover study, this is data now I'm showing from 6 regions, 37 countries. This patients, the participants were recruited when they initiated second-line therapy. And as you can see, they'd had diabetes for about 5 to 6 years on one therapy. They'd been on one therapy for 5 to 6 years before the second-line therapy was initiated. The HbA1c when second-line therapy was initiated was around 8 to 8.3 to 8.6%. And they'd already got microvascular complications, about 20%, and 15% had already got macrovascular complications. So despite all of these complications, we were waiting too long to initiate the second-line therapy. And estimations are that we wait when persons on one oral therapy and their HbA1c is above 7.5%, we wait a median of about 7 years. If they are on 2 oral therapies and we're going into third therapy, we wait 6 years, and patients going forward to insulin, we wait about 6 years. So constantly we are waiting. And this is a global phenomenon. This is a systematic review. We conducted over 50 studies showing that whether we're starting the first therapy, second therapy, third therapy, going on insulin, we are waiting far too long before we manage that patient. And this is why now we're seeing this in the new organ protective therapies as well. This is data from US, 1 million patients, routine database, my friend Mikhail Kossi borrowed. As you can see, use of GLP-1 receptor agonists or SGLT2 inhibitors very low among cardiologists, endocrinologists, and primary care physicians, worse in primary care physicians and cardiologists. If you look at endocrinologists, about 40% are using SGLT2 inhibitors or GLP-1 receptor agonists. And there was this paradox in that people who needed it were less likely to get it. So when we're using it, we may be using it for inappropriate patients. So what are the consequences of therapeutic inertia? Well, you can't do a randomized controlled trial because that would be unethical. So the only way you can do this is by routine database studies. This is a study from the US where they looked at participants who had retinopathy, and they classed people into having inertia or no inertia. And those who had inertia, they had greater progression, 5 times greater progression to retinopathy progression compared to those who didn't have inertia. This is a study, we did it with Sanjoy Paul. Sanjoy Paul, the name may not ring a bell, but he's the person who did the UK PDS analysis. He's a very good friend, and we still continue working together. And what we did here was trying to emulate the UK PDS study using routine data. So we looked at a population whose HbA1c came down from diagnosis below 7% within 12 months, and compared it to those who didn't get their HbA1c below 7% within the first 12 months. That was 26% of the population. And over a 5-year period in this retrospective study, we saw that there was an increased risk of myocardial infarction, stroke, heart failure, and composite cardiovascular events in those who had inertia compared to those who didn't. And we call this the dysglycemic legacy. That's driving the complications in the longer term. And finally, this is from letter Neda Latpong in US, again showing every year you wait, you get increased risk of mortality. So for example, if the HbA1c is high and you wait 6 years before initiating therapy, there's a 54% association with increased mortality, and every year increases mortality risk. So data showing inertia leads to microvascular complications, macrovascular complications, and mortality as well. The other big reason is adherence, and we know from data for the proportion of people who are classed as adherent between 3 to 36 months in these studies. For OADs, it's about 44 to 90%. For GLP-1 receptor agonists, it's 30 to 54%. And for insulin, the estimations are about 19 to 54% are adherent. What does non-adherence do? Not only does it not lead to improved risk factor control, but also is associated with increased mortality and hospitalization. This is a systematic review of 8 observational studies. Non-adherence in this study was 37%, and what we found was that good adherence was associated with reduced risk of hospitalization, so around a 28% relative risk reduction in hospitalization and about a 10% reduction in all-cause mortality. So non-adherence not only worsens risk factors but leads to hospitalization and mortality as well. So what are the solutions to improve outcomes? This could be a talk in itself. These are the barriers that people find. Sorry, it's not come off well. It's therapeutic inertia, patient and physician barriers. And there's lots of barriers. You and I know about this risk of hypoglycemia. We think it may impair quality of life. There's financial restrictions, beliefs that patients may not be competent. There's resource issues. There's complex regimes. So adherence is poor. We worry about excess weight gain, lack of education in certain populations. And these are all things that are manageable by us with the appropriate tools in our armament. One of them is having a combination therapy from the start. This is a VERIFY study. I think most of you know about this, where early combination therapy from diagnosis showed that people were more likely to stay in control of the HbA1c. The HbA1c control here was classed as 7%. And we saw that at the bottom in the blue is the stepwise approach that we do currently. In the top in the red is people who had, in the bottom is combination therapy, metformin and vildagliptin. In the top is metformin plus placebo. And we got more people to target with early combination therapy. We also know that combination therapy with metformin is associated with reduced risk of proportion not failing with HbA1c control. So meta-analysis has shown that if we have combination therapy compared to just metformin, there's a reduction in HbA1c of about 0.43% and about 40% more likely to reach a target of less than 7%. And fixed dose combination therapies, very few studies, interestingly, but they do show positive reductions in terms of 0.5% reduction in HbA1c if we use fixed dose compared to co-administration of the dual therapy. There's lots of interventions to try and improve adherence, dose simplification, patient education programs, reduce the cost of the therapies, improve shared decision making, interventions delivered by nurses and pharmacists, and these have all got good evidence base for them. Finally, interventions to overcome inertia. This is the only systematic review American Diabetes Association commissioned us to do this because there weren't any systematic reviews of overcoming inertia. So what we see here is that, first of all, doctors are the worst at overcoming inertia. Interventions that uses doctors don't lead to improvements in outcomes, and that's, as you can see here, physicians in the second from the bottom. The people who do best is the top, that's pharmacists, and at the bottom, nurse educators. They lead to better improvements in HbA1c compared to doctors or anyone else. And that's why the model of care in the UK is that we're using more and more nurses and pharmacists for managing our people with diabetes. Education programs we don't put as much emphasis on. Just imagine if there was a drug that reduced HbA1c, that reduced fasting plasma glucose, that improved diabetes knowledge on our patient with diabetes, that improved self-management skills, that improved weight, that improved treatment satisfaction, that improved adherence, that improved smoking cessation. We would snap at that drug. Well, there is such a drug, and that's called self-management education program, and it's very, very cheap. In the UK, we've estimated from the trials that we've done, it's about £80 a year. And we don't emphasize enough for our patients to get self-management education programs, but we are easily willing to write a prescription, £100 prescription for a GLP-1 receptor agonist every month. So we should emphasize self-management education programs. So in summary, type 2 diabetes is a progressive disease. It's going to need lifelong treatment. There's strong evidence to support the early interventions in tight glycemic control as well as other risk factor control leads to better outcomes. Despite all the amazing evidence we have, it doesn't get implemented into clinical practice. And we really need to be starting early, just like the UK PDS did, to improve the beta cell function. And combination therapies with complementary modes of action is something we should be thinking about. And we were talking earlier from the UK group that India is really good. We see combination therapy with triple therapies. We just don't have those there at the moment. And even when we do have dual therapies, we don't tend to use them as much. And there are many other interventions that I've talked about that improve risk factor control. But it's really, we need to individualize our plans for that person in front of us to have a better length of life for those patients. Thank you very much for listening.